This is NURS 1202, Chapter 21, talking about the normal newborn. So let's talk a little bit about, we had this in class on Friday. Some of you weren't there, so we'll try to catch you up. The newborn has a pretty good task ahead of it after it is born. This is what it has to do. Within the first 6 to 8 hours of life, the newborn must establish and maintain respirations, adjust to circulatory changes as a result of birth, learn how to regulate their temperature, body temperature, in relationship to their environment, ingest, retain, and digest nutrients, eliminate waste, and eventually regulate their weight. So we're going to talk about the physiologic needs of the newborn. So, of course, we said the first thing the newborn has to do is initiate and maintain respiratory effort. And as you see here, there are several factors that occur. There's chemical, mechanical, thermal, and sensory things that are happening. You see here internal and external stimuli, all right? Let's review the fact that the surfactant that keeps the lungs expanded is usually present by 34 to 36 weeks gestation. And so anything before that, we're going to be concerned about surfactant, and we may have to either give steroids and or surfactant after the baby is born. Also note that as a part of your respiration and your respiratory assessment, that it is not uncommon for you to hear a few little fine crackles in the lungs within that first hour of life. This is particularly true of your C-section baby. The baby that is born vaginally, the chest is compressed during the trip through the birth canal, and a lot of times this compression and it actually kind of forces fluids up more towards so the baby can expectorate them. So within that first hour of birth, you may hear some crackles, but that is not necessarily indicative of something pathologic unless, of course, something else is present, like bad color, bluish color, poor muscle tone, poor weak cry. Then you would be concerned. But these are usually transient. And of course, we know that acrocyanosis in your newborn, the hands and the feet being slightly bluish, is normal for the first 24 hours of life. So the baby has to adjust, again, regulate their own temperature, as we have said before. There's little subcutaneous fat, especially in your preemie babies, all right? There's a larger skin surface, and so the number one thing is they lose heat, all right? And they lose heat by evaporation, conduction, convection, and radiation. And the most common thing we think about probably is the evaporation, okay? This is why when babies are getting ready to be born, we turn on the radiant warmer, and we also place a nice warm blanket on it so that when we lay them on the blanket, it is warm. They don't lose heat through conduction. And then, of course, we don't put babies in front of drafts, air conditioners, and so forth, so that we keep them away from drafts so they don't get convection loss. And then heat loss, we keep them clothed and we keep them swaddled and their head covered and so forth so that they don't lose heat. We dry the baby right at birth. We dry because there's fluid, amniotic fluid on it and all kinds of stuff. We dry it off, we wipe it off. This helps keep the evaporation down, and it helps stimulate baby to cry. We also want to put the skin to skin with mama. That helps keep baby warm. Put the cap on their head because they lose a lot of heat through their head because it's the biggest part of them right now. And then, of course, we want to delay bathing for 24 hours. This is evidence-based practice. There's no hurry to bathe the baby unless, of course, the parents demand it and think the baby's nasty because it has a little blood in its hair or whatever. We don't do that. We typically delay bathing the baby for 24 hours, and that helps a lot with heat loss. So babies keep themselves warm by doing some things, but they do not shiver. They do not actively shiver. So they become more restless and they start to cry by trying to generate heat. They increase their activity. And then, of course, uh, the non-shivering thermogenesis, they use what's called brown fat. They have little areas of brown fat that they use primarily to keep warm. And once those stores are depleted, then they are really at risk for hypothermia, which can lead to respiratory problems and uh, jaundice and all kinds of things. And so we want to make sure that we don't let that happen. So this is in your book. I'm going to skip over this, but you can see cold stress is not good for your baby. It causes all kinds of things. So here are the areas of brown fat. These are not visible. They're not palpable. They're there though. And this is what the baby likes to use first to keep warm. They don't shiver like we said, but they do use up their stores of brown fat. And so brown fat metabolism, it does not shiver. And so again, we're going to dry the baby, skin to skin, cover the head, swaddle the baby, put the baby on the radiant warmer. We want to make sure we're checking those temps. We want them to be at least 97.8 and above, and of course we're doing axillary temperatures. So lots of times they may stay under the radiant warmer until they're at that level, and then maybe we send them out to be with mama, and then we bring them back and we check again because we don't want them to drop their temperature, because that could also cause them to drop their blood sugar and all kinds of things. Okay, so erythrocytes, hemoglobin, and hematocrit, they may have a little bit of elevated white count. Well, let me back up for a second. We do get cord blood. We clamp the cord next to baby with the cord clamp, and then we cut the umbilical cord, and then we get a little blood from there, cord blood. We send it to the lab for typing an RH factor, positive or negative, and blood type. Also, the baby may have an elevated white blood cell count, but it might not necessarily be indicative of anything bad. We're going to investigate other things. We're checking mother's history to see if she's GBS positive, if she's had ruptured membranes greater than 24 hours, etc. In this white blood cell count, we're going to look for increased neutrophils to help us know if this is a true infection. We know that babies don't have enough vitamin K in their body, and so that's why when they're born, shortly after they're born, we do give them a vitamin K injection to help activate those clotting factors. The GI system, the little tummy is quite small, as we know, so we don't overfeed them. The meconium, or that black, tarry, greenish colored, sticky kind of stool they have at first, is usually passed within 8 hours of birth. The baby has to be able to suck, swallow, and breathe. They have to be able to coordinate that. And really, we should be able to hear the audible sucking and the audible swallowing. All right. 5 to 10% of the birth weight may be lost in the first 3 to 5 days, but they should regain their full birth weight within 10 to 14 days. The regurgitation versus vomiting. Regurgitation is often a result of overfeeding, what we also often call spitting up. Vomiting is usually pretty projectile, and it's quite significant, so you won't get those confused, I would imagine. We want to make sure that we hold the baby upright, whether we're breastfeeding or bottle feeding, because their little the cardiac sphincter of their little tummy is not closed, and so if we overfeed them, then that's going to come up their esophagus, and they're going to either spit up or possibly vomit. So keep the head up above the level of the stomach, obviously. Now here's a picture of some stools for breastfed babies, how they transition from the meconium and so forth. So you can see the colors change a little bit. The baby will probably not get brown stools for a while until they start taking in other sources of food. Breastfed babies are rarely constipated. The breast milk is so easy for them to digest that they are very rarely constipated, and we know that breast milk is best. Now here's some pictures of a baby that is bottle fed. You see there the meconium in the top left. And then as the stools start transitioning because they're taking in food, then they're going to have more formed brown stools. They typically don't smell really bad, but eventually they may develop some odor. Uh, so if you're going to have a child, you're going to have to change dirty diapers. Okay, blood sugar is very, very important for your newborn. They use their glucose rapidly, again, with that brown fat. And so that's why we keep them warm. We don't cold stress them, etc. Infants at increased risk of hypoglycemia, of course, your early babies, anything that's small for gestational age. Just because a baby is big does not necessarily mean it's always healthier. They often have problems with birth trauma, especially if it's an operative delivery. They're often as a result of a diabetic mother, and they're called macrosomic, M-A-C-R-O-S-O-M-I-A. Macrosomia means a large baby. They're much more at risk for dropping their blood sugars because their mother has been diabetic and they've been accustomed to getting a lot of blood sugar in as a part of her. And so now all of a sudden that's cut off and they can very, very prone to dropping their blood sugars quite dramatically. Okay. The cold stress is a very, very significant thing as well. Hyperbilirubinemia, and you're going to hear a little bit more about that a little bit later, but it usually is not uncommon. It occurs usually after the first 24 hours of life as a result of hemolysis of red blood cells and liver immaturity. So the liver and the circulation cannot get rid of those broken down red blood cells, and they come out as they manifest as jaundice, right? Pathologic jaundice begins in the first 24 hours of life. The physiologic is after, so there's a difference. Pathologic jaundice is concerning because if we let the level get too high, they can actually suffer brain damage, excuse me, brain damage, my fault. But we can, lots of times if we can increase their fluid intake and get them to have more frequent stools because that's how the bilirubin is removed, and also maybe start some phototherapy where they go under the blue light, the Billy light. So sometimes even breastfed babies can get some breast milk jaundice. That doesn't mean they shouldn't breastfeed, but it's usually just a lack of insufficient intake when we're waiting for the true milk to come in. True breast milk comes in after 3 to 5 days of life, and so it usually is transient, but of course we're going to keep an eye on those sort of things. And this is from your book. You can read this on your own. Some risk factors for elevated bilirubin, the erythrocytes being broken down and so forth, lack of albumin binding sites, liver immaturity, very, very common. Blood incompatibility, that's maybe when your mama is an Rh positive and your baby's an Rh negative. Usually for the first baby, we don't have a problem, except maybe with some jaundice. If the mama does not get RhoGAM, and her next baby is Rh negative and she's Rh positive, the mother's body will attack the baby. It will actually see it as an antigen, and the baby can die. So if we suspect that there's an Rh incompatibility, we'll investigate that, and maybe mama will get RhoGAM before she goes home. Premature and late preterm babies, again, because their liver is so immature and it cannot synthesize these broken down red blood cells. About 60% of all term infants may have an elevated bilirubin of some type. Maybe not dangerously high, but it'll be elevated. Also, some things, traumatic births resulting in bruising or cephalohematoma, which we'll talk about in a little bit later. Other factors, diabetic mothers, and so forth. So we'll talk a little bit more about that in another session, but sometimes if we're going to check the bilirubin, we're going to stick their heel, send a blood sample to the lab, get a bilirubin level, and depending on the level, we may put them under the phototherapy, and we'll just keep checking it until we see it go down. So at birth, about 40 milliliters of urine is in the bladder of the baby, and sometimes when they're being born, they'll actually urinate. It can happen. They really, within day 1 and 2, they should be voiding 2 to 6 times. And after day 4, then we want them to have 6 to 8 wet diapers a day. Okay. Let's see, because the baby has such a much greater amount of percentage of body water that's body weight, they are very prone to dehydration. So any kind of vomiting and so on could be a problem with this baby. Usually they void within the first 24 hours, and then sometimes sooner than that. Let's see. Yeah. Okay. Also, sometimes in that first couple of voids, you might see in the diaper what looks like, could look like blood, but it's called brick dust. We don't know why. It just happens. It could be some red blood cells just being excreted. Unless it's bright red and continues, it's not a problem. You just need to be aware of that. Brick dust. Their immune system, we know, is not fully developed, and so it is less effective at fighting off infection. And so that's where your risk for diagnosis, risk for infection related to immature immune system is part of your nursing diagnosis for your newborn. So we want to really, really watch our infection control processes. We're washing our hands. We're doing our scrub. We're teaching mom and daddy to wash their hands. If someone comes in with a cold that's visiting, right now a lot of people are still wearing the mask, and we may have them mask up. And so a sick baby does not look like you would normally think. We don't have a raging fever. The white blood cell count may not be elevated, but they're lethargic. They don't want to eat. They may have a weak cry. Their skin may be kind of pale with mottling. Their stools start to slow down. They don't have as many wet diapers as they should. And the big thing is they're not interested in eating. That would be a big sign of a sick baby. So we don't typically have that, but we definitely want to be aware of it. So your baby has different times after birth called reactivity. The first period of reactivity, that's after birth. Usually they're wide awake. They're looking around. They're moving. They're checking out their new environment. And so that's when they're most interested in eating, and that's when that first golden hour we talked about. That's when they're more likely to want to breastfeed and be next to mama. And so definitely we're going to keep them warm, watch those vital signs. A lot of the things that we can do, we can put baby right next to mama, skin to skin, cover the baby with the blanket, put the little cap on, and if we need to do heart rate or something like that, we can slip our stethoscope under the blanket and so forth. And then after they've had a little time of reactivity, let me get my reference here. Oh, I forgot it. Here we go. Okay, I'll just give you a few little numbers. So the first period of reactivity usually lasts about 30 minutes to an hour. Okay, the heart rate may initially be fairly high, 100, maybe up to 160, and then as they kind of get calmed down and they get next to mama, their heart rate and their respiratory rate may drop a little bit. And then their period of decreased responsiveness can last anywhere from an hour or more, and they're going to want to sleep. They might wake up and cry if they're disturbed, but otherwise they are really out. They're really sleeping. And so after they've had this a little time to themselves, then the sleep phase, and then the next time, their second period can last 2 to 8 hours after birth, can last from 10 minutes to several hours. They may have their color maybe get better. They're more interested in eating, etc., etc. And so oftentimes throughout their transitioning from intrauterine to extrauterine life, they may have cycles of deep, quiet sleep, light, active sleep, where they wake up with just a little noise. They may be quiet and alert and looking around, and then they may be active and alert, and then they may be crying. So not every baby goes right through these stages in nice little neat steps. So just be aware that that first period of reactivity, that's very important. That's part of that golden hour that we've talked about. And the crying, mama will learn, and if you are around babies very long, you'll learn the difference between a hunger cry and a cry of I want someone to pick me up, I'm cold, I'm lonely, something along those lines. Slow number 2, we're talking about the assessment, including the APGAR and the importance of testing reflexes. All right. So when the baby is born, the number one thing they have to do is we have to get that airway open. And so oftentimes, depending on your situation, especially when the head is born, typically they wait and not rush the rest of the body. They'll go ahead and suction the baby's mouth and then the baby's nose, because babies are obligate nose breathers. They have to be able to suck, swallow, and breathe, and so they have to be able to breathe through their nose. If you stimulate the nose first, they're going to breathe in sharply, and everything that's in their mouth and in the back of their throat can be sucked down into their lungs. So that's why oftentimes they'll suction the mouth and get all the gunk out of there that might be there, and then suction the nose, and then go ahead and deliver the rest of the body. Sometimes docs will delay the crying as much as possible until they can actually take a laryngoscope and look at those vocal cords to make sure there's no meconium staining if you had that. And they'll go ahead and suction them out and then let them cry. So it depends on your situation, but everybody likes to hear that first cry, of course. But you're looking at their airway. We're talking about the APGAR scores here. We've already talked about acrocyanosis as being normal, and we're going to talk about look a little bit at the temperature business. So your initial physical assessment is your APGAR scoring, your heart rate, your respiratory rate, your muscle tone, your reflex irritability, and your generalized skin color. And this is where your health assessment, inspection, and general survey come in. How does the baby look? And then, of course, you're going to get your stethoscope on there and listen to their heart and so forth. So here's the APGAR: appearance, pulse, grimace, activity, and respiration. Okay, and you assign points. Okay, lots of times on the appearance they get a 1 because they do have the acrocyanosis. The pulse should be greater than 100. You're grimacing. As far as if you're suctioning their mouth and their nose, they don't like that and they grimace or they may cry. Their flexion, they may be moving their arms and their legs and flexing things. And then their respiratory, their breathing should be, they should have a strong, lusty cry. Here's a little guy with some pretty significant acrocyanosis. I hope you can see it. He looks pretty good, but his little hands and his little feet are kind of bluish. Here's another picture. It's kind of not real plain, but he definitely has some acrocyanosis. This is how we take the temperature of the baby. We put the tip probe long ways, and we make sure that the tip is tucked up securely inside that axilla. And then we're going to hold the little arm firmly against the body, and the baby may squirm, and he or she may cry. It's okay. It's not hurting them. They just don't like it mostly because they're being restrained. They don't like to be held down like that. So here are your normals for your respiratory rate, your apical. I have, in my experience, I've not seen very many babies get their blood pressure measured, but you might. The temperatures you see here, 97.7 to 99.5 is considered normal. So we're looking for any kind of anomalies or unusual things that we would not anticipate the baby to have. We're looking for, now molding is that their head molds to get through the pelvis and the birth canal. And that usually, sometimes we call them a cone head, but that usually goes away within 24 hours. We're checking the fontanelles. We're looking for something called caput succedaneum. That's it's a little bit different than molding. A cephalohematoma, that would not be something you'd like to see. And then we're looking at their facial symmetry. Again, your general survey. How does the baby look? This is how we palpate the anterior fontanelle. You just take your fingers and go over it very lightly. It should be smooth and even with the rest of the scalp. We don't want it to be bulging. We don't want it to be depressed. We want it to just be there. And then we don't typically palpate the posterior, but you can. So this is the top photo, of course, is normal. Then you've got the subdural hematoma and the caput. Okay, a little bit different. The caput is usually to one side, and the hematoma is more pronounced on the top, but it does not go over the side of the head usually. Now, all of these conditions will go away on their own most of the time. But these babies that have these things are more prone to having elevated bilirubin because the cells are breaking down. There's your caput. A little bit different than molding, but the caput is a little more pronounced. And you can palpate the little soft thing there. There's your cephalohematoma. You see it's kind of to one side more. Okay. You're looking at their neck and their clavicles, although they don't really have a neck at this point. But you're palpating the clavicles to make sure that there's no crepitus or signs of fracture. You're looking at, when you look at the cord, the doc will usually look at the cord when they cut it. You're looking for 3 vessels, 2 arteries and 1 vein. You better remember that, or I'm going to have a fit. But anyway, look at their hands and feet. Since they have 5 toes on each foot, 5 fingers on each hand. Their hips, lots of times, you may notice a difference in symmetry of leg folds, which could be a sign of hip dysplasia. We do not typically check for congenital hip problems. That is not a nursing job. That's physician or advanced practice nurse maybe. And then, of course, their vertebral column, you just turn them on their side and just run your fingers along their little backbone, make sure that it's all intact and there's nothing missing. Measurements are very important because we start putting that on their growth chart as neonates, and then infants, and then on up. We get the weight, and you saw pictures earlier of that, how that's done. The length we measure from the top. We take a paper measuring tape. We put it at the top of the head. We hold it there at the top of the head, and we pull out one of their legs and hold onto it and stretch out the tape, and we measure how long they are. We measure the circumference of the head and the chest. We might be checking reflexes. We'll talk about that in just a minute. We're looking at their eyes and their ears. And also part of your assessment, you're going to check inside the mouth to make sure that there's no cleft palates. Here's how we measure baby. You see at the top of the head, and we hold the baby. Now this baby's pretty chill. Sometimes they don't always cooperate quite that much, but he's pretty chill. Now these are the different reflexes. These are in your book. As a nurse in the nursery, we don't typically go around doing this. A lot of physicians will do this as part of their initial exam. Sometimes these are not even done until they're, in their first clinic visit. But you see all of these things that can be tested as far as reflexes and so forth. And again, lots of times the startle reflex will happen, as a result, someone bumps into the crib, or they throw their arms up, they're scared, they're startled, okay? And then they have the grip, how babies grip your fingers. When you put your finger in their mouth to check their palate, they probably will suck on it. And then you have the others there, and these are all pretty standard. And again, we don't typically do this as registered nurses, but there they are. Ear location, we see here a normal ear location about the level of the corner of the eye, and then the low set ear could also be a part of your fetal alcohol syndrome baby. We've already talked the importance of blood sugar. We're looking for signs and symptoms of hypoglycemia, and I will just tell you on this slide, myself and other instructors don't agree with this blood sugar of 30 milligrams in the first hour or two of life. Most places, if it's below 40, they start treating it. And so that's, we'll just let that go. Blood samples, again, are obtained by a heel puncture. And we do it just like with a regular blood sugar. But again, 40 is usually the most common that I have seen. I would not want my baby to get down to 30, because by that time you're going to see some symptoms. They're going to be jittery, startle very easily, have some tremors, They may have some decreased level of activity, and so forth. This is where you stick the heel on the sides of the heel, not on the bottom or in the middle. Here are some signs of hypoglycemia. Diaphoresis is a very, very, very late sign. Low temperature is a very late sign. Don't wait till that happens. If they're jittery and starting to tremor and having poor muscle tone, especially if it's your mama that's a gestational diabetic, make sure you're watching that. And then if you just feel like you want to check a blood sugar, it's okay. It's fine. All right. If you feel like it's warranted, you do it. It says here some babies may be asymptomatic, but it's not very common. Okay. We've already talked about how important it is to check the status of the mouth and make sure that they can swallow and suck at the same time. Their little abdomens are, you can usually hear bowel sounds, and we've already talked about the stools. Okay. All right. The genitalia on a term newborn, the female, the labia majora is very large and completely covers the clitoris and the labia minora. And so, but in your smaller, your more preterm baby, it's going to be the opposite. Your labia majora is going to be very tiny, and your clitoris and your labia minora is going to be very obvious. There may be a small amount of vaginal discharge from your female, mostly white. Whitish discharge. There's nothing to be concerned about. Your male term baby, the scrotum should be pendulous, and you should be able to palpate the testicles. And of course, the baby will come, with a foreskin, and then they may determine if a circumcision might be necessary. That's a personal choice. There's no medical indication for it. It's a personal choice. I don't like this picture, but there you go. There's a very good picture of the genitalia of a female, and there's their male. Their skin, you can have some interesting things show up, but also know that in particular, the male baby, we want to check the urethral opening. It should be, of course, at the end of the penis, but sometimes it's on top of the penis or underneath. And so if the urethral opening is on the underside of the penis, it's called hypospadias, Hypospadias. If the urethral opening is above the penis or on top of the penis, it's called epispadias, Epispadias. Okay, those are unusual, but you always have to look. So your integumentary system, vernix caseosa, of course, is that cheesy cold cream type of substance. Mottling is not real common. Lanugo is. Milia is. Birthmarks can be. You can have marks on the face from forceps. You can actually have lacerations sometimes from when they did the C-section. Very unusual. And we've already talked about the breast. The hair, some babies will have a lot more hair than others. Sometimes the nails are quite long and they may scratch their face, and so we may have to clip them. Okay. And the breast in both male and female can be enlarged. Some may have a little discharge from the breast. We call that witch's milk, but we don't see that very often. Okay, here's a great picture of some significant vernix caseosa. We don't wipe it off. If we have this much, we might want to wipe some, but we typically just let it soak in, or we can rub it in like lotion. And they need this because when they're in the womb, if they don't have this covering them, they'll be all shriveled when they're born. The picture on the left is the lanugo, the little fine downy hair, usually on the back. This goes away after a while. The picture on the right is a picture of some Mongolian spots, and it looks like there's bruising, but it just is something that happens. We're not quite sure why, but it's insignificant. Usually goes away in a few days, and of course parents are worried, and so we have to explain that to them. Slow number 3, the physical criteria for determining gestational age. I'm not going to spend much time on this because this is typically, again, not done by registered nurses. Um, these are the tests that can be done. Their posture, their square window test, arm recoil, popliteal angle, scarf sign, and heel to ear. These are done quite often in your baby that is preterm. We want to try to determine if our ages are off because we've got confusing dates as far as mama's last menstrual period and so forth. Again, these are not done by nurses. These are done by medical students, advanced practice nurses, etc. But just be aware that they're there. This is called the Dubowitz chart, and you can see that the posture, your preemie baby will use is pretty flaccid and just lays flat, whereas you see the term baby more over here on the right. They're flexed and so forth. And so, if you ever get to see these, it might be interesting. I personally have never done one. Um, Also, another thing that they look at is the soles of their feet. A preterm baby will have will have very smooth surfaces on their feet. A term baby, there's lots of wrinkles on the bottom of the feet.